good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Anita Malik. Ma'am is MBBS MD, radiation specialist, oncologist, and unit head at IOCI Fortis Hospital, Noida. Now, with the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is Beyond the Swallow, a case-based insight into esophageal cancer challenges. Now, without any further delay, I would like to welcome ma'am and I would like to hand over the session to her. Over to you, ma'am.
Thank you for such a nice introduction. And good afternoon, everyone there. So, after completing this session, we will be happy to like to take the questions. And meanwhile, you can put your questions in the chat. So, this is a unusual case scenario. Esophagus cancer patient was diagnosed and then started on treatment. So I will be presenting a case first, and then we will discuss this scenario in general as like etiology, symptoms, and what are the treatment options. So a 54-year-old male evaluated in remote area in a town for chronic cough and bronchitis, and these symptoms were there for 2 months, approximately 2 months. The other symptoms associated with him, he reported weight loss, and that was very mild, 5% weight loss. And there was chest heaviness, especially post meals. So there was no dysphagia, no other symptom, and these were the only symptoms. There was no significant family history, and there was no comorbidities like hypertension, thyroid, diabetes. No other comorbidities was there. So in that remote area in his hometown, he was evaluated by a chest x-ray that was absolutely normal. ECG was absolutely normal, and the general practitioner, they were wondering what is happening to this patient, why this bronchitis is not going. And the other parameters were absolutely normal, and he was a smoker. He had a addiction of this tobacco in the form of smoking. So at that place, no other investigation like CT and these things were advised. Only that GP said, ki, no, I know X-ray, just do a barium swallow. So barium is a radio opaque substance that is given, and after that, this X-ray was taken, and typically it showed a rat tail appearance in the upper thorax part. So we might have learned in our undergraduate time that the esophagus cancer, they typically the radiological feature is like rat tail appearance. So from that point of time, the practitioner, they discussed this as case to us, and then when he came here, he was evaluated further. So the talking about this esophagus, this is a fibromuscular tube, and its approximate length is 25 centimeter, and this tube is located in mediastinum behind our trachea, and behind heart, and it is present in front of our spine. And this food pipe tube is starts from back of our mouth, and it passes through the diaphragm and connects to the stomach is our food bag. Our food is stored in that, and gradually this with the digestive enzymes, it get break down and it passes through the intestine. So this is a connecting tube between our mouth and this food pouch stomach. So what is the function of this tube is it is a transit food passage, and with this sphincter, this avoids the reflux back coming of the food through this. So this pipes um, prevents the reflux, and because there is a sphincter here, so this cancer or the malignancy that happens in this passage, and usually the patients, they have a symptom of dysphagia, not able to have food, and pain while passing food. So typically in this case there was no such like symptoms, the only the patient have bronchitis. So what may be the this what is the cause of this symptom? Might be the food is regurgitating through and is going into the lungs, and which repeatedly causes like chest infection. So this patient, they presented with bronchitis, recurrent chest infection. So this may be another symptom of this disease. So, what is the cause of esophageal cancer? So, when we broadly see esophagus cancer, it these are of two types. It may be squamous cell or it may be adenocarcinoma. So, the etiology is entirely like there is a spectrum, and the causes are different. In squamous cell, the tobacco, alcohol is a major risk factor, and if the both these factors are present, so though these increases the risk synergistically. uh, Other factors like dietary factors, if the patient or the population is not taking fruits and vegetables, the intake is reduced, and if there is increased consumption of hot beverages, carbonated drinks, nitrosamine or acetaldehyde in the form of preservatives, so that again increases the risk of esophageal cancer. So betel nut chewing, it is common in Asia, and this therefore this cancer is increased. There is incidence in this population, and these factors, when they are combined, the numbers, it synergistically it increases the risk of cancer. And there are certain genetically susceptible variants which change the lifestyle. So these the risk further increases. Talking about adenocarcinoma, which is common in the lower part of the esophagus, which is urinary gastroesophageal reflux disease. So what happens in that disease? The lower esophageal sphincter that becomes lax. So that doesn't function like normally. It doesn't stop the food for regurgitating, and from this lower part, the food frequently comes out in upward direction. So the mucosa of this lower part that changes. So that is known as Barrett esophagus. So it is a kind of pre-malignant condition. So if it is not corrected with the medications or small surgical procedure that is required in this, so it can turn into adenocarcinoma of lower esophagus. So another risk factor is the obesity, which again increases the risk of GERD, and again smoking as associated with squamous cell also. It is again associated with adeno CA also. Dietary factors common in the both. So other there are other identified risk factors are the HPV infection. Poor oral health is again found to be associated with esophageal cancer. So what are the common symptoms with which the patients are presenting to us? Maybe the most common symptom is difficulty while swallowing. So that the term is known as dysphagia. So food, when the patient takes food, it the patient felt like it is stuck in the throat or chest. So over the time, it become worsen. So that may be this is the most commonest symptom. The esophagus patient, they are coming to us with this. So other symptoms may be chest pain or pressure symptoms, It may be persistent or intermittent. Pain may be felt behind the breastbone, so that is the sternum, and sometimes it may be mistaken with heartburn. So there may be unintended weight loss, maybe more than 20% in over the period of few weeks, like 3 weeks, 4 weeks, and during which this swelling difficulty may persist with that, and there is reduce in appetite. So talking about reduce in appetite, it is common with almost all cancers, and patients, they don't feel like eating, so these can be there. Another symptoms may be hoarseness or chronic cough. As the cough, this patient was diagnosed with the our patient was diagnosed with this bronchitis. So this was the main presenting complaint. So the persistent changes in voice and coughing may be the symptom. So why this hoarseness? How this happens? So because of the involvement of recurrent laryngeal nerve on left side, the course of recurrent laryngeal nerve is different. So that may again a tumor or a mass which is compressing this nerve, that may cause hoarseness. So sometimes this can even happen, and this is also common with lung cancer, especially in the left middle lobe. So there may be regurgitation, there is backflow of the food into the mouth, and again that can cause the um, aspiration and frequent chest infections. So, other less common symptoms are persistent hiccup, vomiting, coughing of blood, fatigue, bone pain, retrosternal pain, and in late stage when there is involvement of the liver, and there is, so in that case the patient may present with jaundice. So so the patient then evaluated, and these are the common modalities which are used to identify which or to diagnose a case. First picture, this showed a picture of a upper GI endoscopy with the scope. The surgeon can see ulceration in the esophagus, although the lumen is intact, but here there is ulceration. So sometimes the proliferative growth is there that can completely obstruct the lumen, and the patient may have permanent these symptoms. So if the ulceration is not visible and there is something compressing, in that case the ultrasound guided endoscopy is advised, and one can see that from outside there is a compression of this esophagus, and this is a scope, and there is something in the outside lumen or in the lumen that is compressing. So it can be a esophageal cancer tumor or a node or any other thing which is compressing the lumen. So this is how, like, this is visible in the scan. So after this, if the scan growth is visible, the biopsy samples is taken to identify which type of tumor it is, whether it is a squamous cell or adenocarcinoma or any other variant is there. So the once the biopsy is positive, so patient can underwent a PET staging thing, and in which you see that this has had a liver, sorry, the brain normal uptake, because the brain cells, they are consuming the glucose, and so there is uptake, and the cells which are consuming, actively consuming glucose, they are there is enhancement in that area. So in this, the esophageal area, there is enhancement. So PET is very good modality for staging. It is not meant for diagnosis. For diagnosis, upper GI endoscopy and biopsy is the standard of care. So this patient, it was diagnosed with upper esophageal cancer, and this was staged. And the treatment depends on the stage, what stage it is. If it is localized, so treatment will be different. If it is a metastatic, the treatment will be different. And treatment also depends on the histologies, because squamous is sensitive for radiation, and adeno and lower G junction tumors, they are more like prone for like they are good for surgery. So neoadjuvant chemotherapy is given, and then these are operated. So it depends on the histology and location what the treatment is advised, and the sequencing, the combination of treatment. So that all depends on the stage and location and histology. So usually what is advised is in the form of systemic therapy, chemotherapy, immunotherapy, targeted therapies are advised, and radiation is a local treatment, usually in localized tumor. Before going for a definitive surgery, radiation is advised. And surgery is main treatment for middle and lower esophagus. And in upper esophagus, it is meant that the space is very less. The patient should not underwent surgery. In that case, the radiation in with extended course is given on, especially in upper esophagus. So, talking about the treatment side effects. So, you will see n number of side effects when you see the literature. In the past literature, when the treatment were not that good and precise, so there were the patients were facing these side effects. And the side effects depend on the type of treatment, the type of drugs, and the tumor size, because especially talking about the radiation fields, those depends on the tumor bulk and tumor length. So the common side effects are fatigue. Even the tumor causes fatigue, and the treatment again causes fatigue. And almost 95% of the patients, they feel fatigue during the treatment. There can be skin changes like dry, itching, peeling, and blisters. So blisters, no more we are seeing with this newer radiation techniques. It is not seen. The other symptoms may be nausea, vomiting, diarrhea, and difficulty in swelling. These are frequent. So once you give treatment to this and the passages are open up, but the further treatment again cause mucositis, either the radiation or chemotherapy. But when we see these treatment in long term outcome, these are very good, fruitful these days, because many of our patients in early stage up to stage 2 and 3, they are getting cured. So we should see these things in a very positive way. So another symptom, when the patient is taking treatment and in mouth and throat, they can have discomfort or soreness or dryness, typically due to mucositis and certain drugs, the medications, treatment related medications, they can cause these symptoms. So what are the late side effects of local therapies? So there can be fibrosis, stricture. So these side effects, these are reported in literature as per the previous treatment modalities. Now these days we are not seeing these late, especially late side effects. So there can be cardiopulmonary complications because significant radiation is going into the heart and lung. And again, talking about the systemic therapy, they have impact on heart and lung. So what we do is, like, we evaluate the patient in pre-treatment setting, in during the workup. And we use the medications, drugs which are not that harmful to the patient. And again, talking about the radiation, we can limit our dose to the remaining lung and heart. So these side effects are not that we are seeing in our patients. So there is a risk of developing secondary cancers, although these risks are very less than 1 or 2% of the patients, they have risk of developing secondary cancers, because the normal tissue is getting radiation, and the chemotherapy, they have long term impact. um, and these patients, if they live long, more than 20-30 years, so they may have a risk, which is although very less, of developing these secondary cancers. So there can be breathing problem due to chronic radiation pneumonitis that can cause cough and breathlessness. These are the known side effects, but these are less again. So talking about the skin reactions, you can see these reactions. We are not seeing this kind of reactions. Maybe patient probably treated with a cobalt that can have these kind of reactions, because there is deposition of dose in just below the skin. So we are not seeing such side effects. Hardly 1 or 2 shade darker skin can happen. So So this is not visible. So post-surgical complications can be respiratory complication, pneumonia, atelectasis, lung abscess, respiratory failure. There can be an ostomatic leak, which with high mortality of 7 to 20%. There can be chylothorax, thoracic duct injury. There can be digestive issues like gastroesophageal reflux, heartburn. Um, so these things can be happen. There is theoretical risk of these things, but with the development of specialized surgeries, robotic surgeries, we are not seeing patients with these complications. So these are very, very less during these days. So, talking about the follow of these patients, there is no clear cut guidelines. When we see the NCCN, they are not advocating PET scan, but when you see these days, the doctors they are advising PET scan. So, what is the reason? Because, like, if you see a doctor sitting in a government setup, they don't have that facility. They cannot advise those patients, every patient, a PET scan. But yes, if the patient is stage 3 onwards, 3 or 4, one should do a PET scan. And usually in esophagus cancer, in every 3 to 6 months, we advise a complete history physical examination, and using the CT scan or PET scan, whatever is available, and endoscopic ultrasound guided visibly, one should see what is the post radiated area and what is the position of anastomotic site. We should see every 3 monthly in first 2 years, then we can reduce the frequency of this. So in post-op surveillance, there is no consensus again. So what we follow is like every 3 to 6 monthly, we advise these scans and one endoscopic evaluation. So this can change if the any physician suspect any symptom of recurrence. So one may change the frequency, and it depends on the patient needs. Suppose a patient comes from a remote area, so one can advise according to the availability of the modalities in near vicinity. So I will be happy to take questions now, and thank you for having patience and listening me.
Thank you so much, ma'am, for this wonderful presentation. We do have some question if you like to take that up.
Yeah, please. Yeah, please. You
So,
can
ma'am,
ask.
the first question is, how do you decide between an esophagectomy and define uh, chemotherapy for locality advanced esophageal cancer?
Okay, so once you see a patient of esophagus, we consult with the surgeon like if it is a surgically amenable or not. We can able to remove it or not. So if it is localized and if it is in the mid and lower esophagus, and there is only loco-regional spread, the lymph nodes are there. So in that case, surgery is the main modality. And before going for surgery, surgeon says we need a clear planes, so that you should give some neoadjuvant therapy in the form of chemo, radiation, or chemotherapy, so that we can shrink the tumor and surgeon will get clear planes. Because in esophagus, that is a very small area. Heart and the coverings of pericardium is there, and one side there is trachea, and another side there is lung peritoneum is there. So in that case, upfront surgery is not a good option. One should shrink the tumor and then get it operated. So the surgeon during surgery cut that area, and surgeon create a esophageal tube from the stomach upper part. Sometimes this happens. So new adjuvant therapies are required in esophagus. So talking about upper esophagus, So surgeries are difficult because this is very narrow space. If surgeries are attempted, one can land up in going to remove the voice box. So in upper esophagus, what is preferred is the radiation and chemotherapy. And here, if radiation and chemotherapy is given, so in that case, chemotherapy is in very milder doses, maybe weekly or 3 weekly, and the purpose is to the in that case the chemotherapy act as a radiation sensitizer. It potentiate the effect of radiation.
Next up, ma'am, in a patient with chronic GERD and a family history of esophageal cancer, what would be the ideal screening of protocol?
So, as I told you, there is in follow up and for screening, there is no robust test. So, what we advise in such scenario, patient for GERD, so there is a small surgical procedure that is known as fundoplication. The gastroenterologist will correct that lax sphincter, esophageal sphincter, and the GERD is corrected. So, and after that, one can do a 3 monthly endoscopy and biopsy if it is required. Biopsy, not in all cases. This is how we can proceed.
Okay. So, ma'am, there's one last question. How do you differentiate between beginning esophageal structure and malignancy on imagining?
Okay. So usually in malignancy there are ulcers. There are non-healing ulcers. There are unhealthy ulcers with everted margins. So strictures are usually the surface is much smoother than what the patients in which there is history of taking corrosives like attempting for suicide, multiple attempts. So in that case we see strictures, but when we see strictures through the scope, it is entirely different when we compare with the esophageal cancer. In cancer it is a ulcer, non-healing, unhealthy, everted margins. So it is different entirely. As we can see that this is unhealthy ulceration. Stricture, there will be the lumen compromise, will be there, bands like things will be seen in the stricture. So here it is ulceration.
Thank you so much, ma'am, for answering all our questions. That's all from our audience. Before concluding, ma'am, any take-home message?
Yeah, so the healthy lifestyle, there should be no addiction. You should take food without preservatives and maintain your weight according to your height. So these are the only things, because in esophagus cancer it is not, the hereditary risk is not known. Maybe in future we will be able to know this clearly, but now, as of now, this is not a have a genetic predisposition. So only thing is the healthy lifestyle and these things. And if the any patient has these symptoms, so one can go for a endoscopies and examinations.
Thank you so much, ma'am, for joining us today. That's all from our audience, and it's our pleasure to have you here in our platform. With your permission, I would like to conclude today's session. Thank you, ma'am.
Yeah, thank you.